Well, welcome and thank you so much for coming to our current topic session. I think we would all agree that there are a few topics that are more current on a consistent basis than population health. I think not only is population health so critically important to everything you all do as healthcare providers, but it's something in my understanding, which I don't understand it very well, is constantly changing. And it's also a difficult concept to understand and to pull together. So here today to help us to understand population health a little bit better and some of the resources that we have and what we can all do from a practical standpoint is Dr. Michael Jeremiah. Dr. Jeremiah is a chair of family and community medicine for Curling Clinic. He's professor for family and community medicine for Virginia Tech Cronin School of Medicine. He's a senior medical director of ambulatory quality. He is the associate professor at the Virginia College of Osteopathic Medicine. He's a family physician, and he's also, incidentally, he tells me, the president of our ACO, which is, I think, a pretty big deal. Also, most notably, he is King Stepper. He's on one of our teams and is killing us all with his stepping. I don't know. He walks everywhere, apparently, because he is killing us all in his steps. So, please join me in welcoming Dr. Michael Jeremiah.
Thank you. I'm glad to be here today. I've never had an introduction that talked about my steps, so that was new. I'll take it. Usually it's when I have a week of vacation, I was at the beach. That's when I can catch up and do that. I'd much rather be stepping than we spend much too much time sitting and meetings and things. So feel free to stand up, walk in place, get your steps, however you want to do that. I will not be offended. I think that'll be great. So I do, when you hear it described, it sounds kind of crazy, and it is at times, because this is a lot going on. So in my role, the reason I can combine some of these different things is because a lot of the work of population health has been centered on primary care, and family and community medicine is one of the departments that has a lot of the primary care teams within it. And so it falls on that group to drive a lot of this, but it can't be done by that group alone. This really does involve the entire system if we're going to do it right and do it well. And that's what I hope to be able to tell you more about. I want this to be as interactive as it's helpful for you, so if there are questions as we go, I'm glad to answer them. I will leave time at the end as well for us to have questions and discussion. So this is an introduction. You're not going to be quizzed, and I do want you to be able to hopefully answer some of the questions you might have had when you came into the room. So let's dive in. So I'm going to start with the aspect that I just mentioned. It is complex. There's a lot that's going on. There's a lot that keeps changing. That was why we had the title of the talk, as it was the only constant is change, because it really does seem week after week there's something new that you have to deal with. That could describe medicine right now. I mean, there's enough going on, but it certainly does for this part of healthcare. So I'll start a little simpler. These are 5, maybe simple would be 2, but I'll start with 5 goals of what are we trying to do in population health. And it gets back to even our mission statement. So Curling Clinic exists to improve the health of the communities it serves. That mission has been here from when I started back in 1995 and well before that, and I think it still rings true. You know, I think that is a wonderful mission, but you have to break it down and say, what does it really mean? So improve the health. How do we define improving the health? Which community? How are we defining that? You know, we've become a larger system. We spread over 250 miles. We're made up of now hospitals and a lot of ambulatory settings. Some of the movement is from hospital-based services only or primarily to now much more of a mix. So here's the goal. So improved quality outcomes, obviously. We are committed to quality. We have a lot of people that are working in that may or may not, think of themselves as defined in population health, because that's a goal that we all share, the best quality outcomes. Okay? Risk assessment and capture is something a little more new. That's both in the hospital setting as well as in the outpatient setting. So we always have heard of people who say, well, the reason this is harder for me is because my patients are sicker. Well, now we're getting the feedback of saying, prove it. So if you think your patients are sicker, then are you documenting, are you capturing the complexity of the types of patients you're caring for, the panel of patients that you have? And we'll talk about how we're actually doing it. We want to avoid any unnecessary utilization, meaning visits or services or care in the hospital or in the ED, and the costs that are associated with it. So the ones that can be avoided. And then, are we meeting the needs of the groups that we're trying to serve? And that includes our patients first and foremost. It actually probably includes those paying for the cost, that's the employers and the insurance companies. It includes the teams providing the care, so that's the providers and the staff. And we'll talk about an aspect of that too. And then we've got to be able to sustain this, because some of this work takes new learning, new skills, and investment of time, money, and resources. And this is a time when it's harder to meet those margins that we want to, so any new investments really have to be sustained. So those are the goals. So then we go to a very complicated picture that shows some of the complexity. And this is an ecosystem. This is the healthcare ecosystem. And I have up there, again, the title of our talk today is The Only Constant is Change. Let me break this down. So you've got up in the right-hand corner a formula. And this formula is one way to describe some of this work. It's value-based care. So what is value? Let's define what value is. Value is simply the quality or the outcomes, I would use both words, plus the service or satisfaction we're providing, divided by the amount of effort or cost that goes into that. That's the value. Okay? So if you put, millions of dollars into the cost and the effort, and you're not getting much on the top part of the equation, the value's lower. Okay? Or you can, change any of those variables, and you can see how that's going to change what the perceived value may be. So that's just one way to think about that. So in terms of the value of work around keeping people out of the hospital who have congestive heart failure. How do we do that? If we send education flyers to all of our patients with congestive heart failure, that's a relatively simple, low-cost way, but is it effective? Well, if we have somebody who's going to their house every week, that might be much more effective. It's also much more expensive. So you've got to look at those parts of the equation. Then if you look at the ecosystem itself, you can see that here's all the different parts. It's all centered around our patient, but if a patient is being seen, are they being seen in the ambulatory setting by their PCP or by a specialist? Are they in a hospital setting? After the hospital setting, are they going back home? Are they going to a nursing facility or to rehab? How are they getting there? What's the transportation? How are they interacting with the community, and what community resources do we have to support them? Are we providing care that's not really shown to have that value? Low value services. So every time I see them, if I do an EKG, is that getting them some benefit, or it's just something that I'm doing? So looking at these types of services that choosing wisely as a campaign that the Internal Medicine, the American Internal Medicine Foundation has really had a challenge to all specialties to say, identify aspects of our care that aren't necessarily providing that high value. Okay? And that's been a challenge for us to be able to look at that and then say, we don't really need that. That's not going to really help us. One way in the hospital we do that is if you've just done a lab, a CBC, and you're trying to get another one, it pings you in Epic to say, do you really need that? Did you see the last one? So we don't need those redundant labs if you really aren't following it that closely and need it that closely. Looking at the inpatient side of this ecosystem, we're asking these questions. Do you really need to have the admission? Can the care be provided at home if you have additional resources? If you do need to be hospitalized, what's the length of stay? Can we make sure that we're providing all the services we need to get you the care you need while you're in the hospital, but as soon as you're ready, let's get you outside the hospital. Hospitals are necessary and a wonderful place if you need them, not necessarily great if you don't need to be here. And we've had a whole development of a new specialty, hospitalists, around the aspect of it. In the past, primary care docs would admit, maybe see you in the morning, come at the end of the day, try to see you at the end of the day, 2 points in time, a lot goes on between those 2 points. Hospitalists can be available all day long, attend to those needs, decrease the length of stay, hopefully improve outcomes. And then reduce readmissions. So if you get hospitalized, you get out of the hospital, that critical time, usually defined as the 30 days after you were discharged, what do we need to do to try to reduce the risk of going back in the hospital? Because, for the same kind of condition, that really doesn't look as good. Maybe it couldn't be avoided, but if it can be avoided, we're learning different ways to go after it. Another complexity slide. This is really looking at some of the components, almost the foundation. If you want to do population health well, almost all the components are listed up here in some way. And I know a lot of these terms are new to you. I'm just introducing it as, again, conceptual, and then we're going to dive into some examples. But delegation of clinical operations to improve outcomes and reduce, again, there's going to be acronyms, MLR, so medical loss ratio. That's an insurance term, meaning when you have a premium dollar, $1, then how much of that is spent on the actual services and care, and then how much of it is left over for the profit for the insurance company. Okay, so that's something that they use in terms of an MLR. It also then transfers over to how do you sustain this work, because you're using some of that to be able to invest into the right support and resources to do something different, to do something new. Okay? So we're looking at utilization management, disease management, care management, pharmacy benefit management as aspects of clinical operation. Then you go over to the providers, the provider engagement and network performance. So how are we actually working with and engaging providers? You're looking at, ways to monitor and treat patients in terms of the quality outcomes, in terms of the actual coding and documentation, getting again to risk assessment that we'll show you in a minute. And then this vital layer here, which is the technology and the data. That's what has exploded in the last decade, is the data that's available to us. But it's got to be useful. Data alone is not helpful if you can't understand it, translate it, put it into action. So actionable data, useful data, at the point of care ideally, is what we're aiming for. And then for some systems, if you have insurance groups or services that act as TPA support about the financial performance. We're not going to dive into that as much, but this was a slide that just kind of covers a lot of those aspects. All right, so let's switch gears. Change. This is Heraclitus. And we know why Heraclitus is famous. What he said, anybody read Latin at the bottom there? I'm a little rusty. I went to Catholic school growing up and I did learn Latin. So the Latin roughly translates into you cannot step into the same river twice. Okay? You've heard of that. That's just a metaphor, a description of meaning change is constant. Okay? So things are always changing around us. So if you went into healthcare expecting things to be static, I'm sorry, I have a bad message for you. It's not going to happen. But I don't think any of you had that disillusion right now in terms of we know things continue to change rapidly. And I'll start back with 2015 in relative to population health. This was a big change in terms of this work. This was called the Medicare Access and CHIP Reauthorization Act, again condensed into an acronym which people love called MACRA. This is MACRA. In 2015, they were addressing something that went back to 1997, the sustainable growth rate. Said we keep seeing costs of care for all patients, but they were focusing on Medicare, go like this. Okay, too high, can't sustain it. How do we start to flatten that curve? We know that costs never really go down, but they can't keep going up like this and going faster than the inflation rate. So how do we start bringing that into line? So they passed a law that said we're just going to cap. For all the services, we're going to say you can't get more than X. And then every time they got close to enacting that from 1997 on, they'd back away from that and say, no, this is a game of chicken. And so it never got enacted, and costs continue to do this, never changed the curve. In 2015, in one of these rare acts these days of the legislature, they actually passed something by a big bipartisan margin, okay? 392 to 37 in the House and 92 to 8 in the Senate, and it was signed. And what it does is it says we're going to start paying you differently. We're going to pay you based on outcomes, and we're going to do this in a budget neutral way. So Congress loved it because they say we don't have to pay anything extra. We're not going to raise taxes, we're not going to shift them away from anything else. It's going to be budget neutral, and it has the promise of producing better outcomes. But what it created was the potential for winners and losers. So if you do this work well, you can win and have some of this revenue. Other people, though, are going to be paying it. So it did shift it from who's getting the money, but not from Congress's standpoint.
Okay, so that's why it passed, and what it produced was a time frame from CMS, and they said from 2015, and they went out to 2026, here's what we're going to do. We're going to permanently repeal this old law of 1997, the SGR. We're going to do some updates in physician payments. We're going to give them a generous 0.5% increase from 2015 to 2019, so it's the next year, and then we're going to freeze it. Okay? No more for regular Medicare, no more increases, it's done. And then this system of PQRS, meaningful use, value-based payments, some of which we are still dealing with, is going to roll up into, by next year, either merit-based incentive payment system, MIPS, or an APM, which is an advanced payment model. So you one or the other, MIPS or APM. Okay? The difference is that this one pays better. APM pays better. You get a 5% bonus for being in there, for doing the work and the investment that you're doing, and you get an annual update starting way out here, 0.75 per year increase annually compared to the 0.25. Okay? Now, if you look at these numbers, and again, I don't know if you can see the numbers, but I'm going to tell you, there was this theoretical in MIPS of you could win or lose up to 4% in 19, and went to 5 and 20, 7, 9. And you think, well, wow, I can make 9%, and I can only make 5 here. The problem is though, that this has to be budget neutral. And it's estimated that nobody's going to get near 9% because there's not going to be enough money into it to be able to pay that at MIPS. So the only way to have more of a guarantee is to do the work to qualify as an APM, and you get to 5%. But they set the bar pretty high to be an advanced payment model. You had to be in a program that took on risk. So you actually had risk of paying things back, okay? That'll be important. I'll come back to this of how has our journey been and where are we in terms of risk. And the change doesn't stop. So some highlights, you can see Tom Price was the HHS secretary, and now he's not. Anthem was the third insurer in that period of time about the exchanges, something that came out with the Affordable Care Act and with Obamacare, and we all of a sudden had a gap, and then Anthem came back to the table, and we did have coverage for some of the barrier areas, which included us here locally. Then just this past year, we've approved Medicaid expansion to cover 400,000 more, roughly, low-income residents who are not qualifying at this time. Just recently, in this past month, CMS proposed a change to the way, again, that we get paid. This is more paid for the coding. This is the documentation piece. So for evaluation and management codes, what we call E&M codes, they are going to take the 5 different codes, there's 5 levels, and shrink them into 2. Okay? Sounds good, but then you got to look at the fine print saying how is that translating into how much they're paying, and would we get more, get the same, get less? Don't think we're getting more. Just put that in. All right. And then bundled payments is another way of starting to push change. They're saying instead of paying you for each and every service, that's the classic fee-for-service way of paying. So the more patients that John sees, the higher he codes, the more that the system makes. Okay? Bundled is more of what we call a capitated kind of payment. So it's saying for a whole range of collection of services around an episode of care, you get a flat amount. So if John was an orthopedic surgeon, which he's not, but if he was, then bundles are something that exists for that type of episode of care. If he's doing a hip replacement, here's the amount of money for the pre-op, the operation care in the hospital, and the post-op care up to a certain period of time, 30, 60, 90, depending on the bundle, all in one. Here's the money, here's what you get. And then you've got to make it work. If you can do good quality care, come in under the amount, you've made a profit. If you end up spending more, you've had a loss. And then altogether on all the episodes of care, you've got to sustain and make that work. Okay. So that's capitation. That's a bundled around an episode of care type of capitation. Then there's larger capitation, and this is very common out in California right now, where you'll say for your 100,000 patients you have as a system, here's your capitation amount, you're responsible for all the care, go get them. You got to be really good on your data, really good on your processes to be able to make that kind of thing work. Okay? But that's the pressures and the change that we're living in right now. So what about us? So our Yellow Brick Road, what's the path that we're following? So if we go back to 2009, we developed or we adopted a model of care called patient-centered medical home for our outpatient practices. This was in pediatrics as well as internal medicine as well as in family medicine. It was an idea of saying, we're not just going to have the blinders on and say, when you're here in the office, what do you need? And we're going to make sure that we do our best to deliver great quality, and then we'll see you next time. It's starting to bridge between those visits. What preventative care, chronic care, management of care between sites, in and out of facilities can we do that hopefully will provide more value? Okay, so that's the PCMH model. We were the first in Virginia to get the highest level awarded for one of our sites. It was our Benton site, so we were level 3 NCQA PCMH model, and we went on to use that model across all of our ambulatory sites. Then in 2012, we created basically a tax entity, but it was Doctors Connected, which is our ACO, so that it's an accountable care organization. And that simply means, how are we doing work that falls into this population health value-based care type of effort. It also gives us a way to do contracts with insurers around this work. So we did our first contract with Medicare, with CMS, in 2013. This was the Medicare Shared Savings Plan Track 1. This is what they call an upside only. So in terms of risk, it means if you do the work well, we can earn additional dollars. You don't do the work well, we don't pay any penalty. Sounds good. I like it. All right, so we did that for 4 years. We showed some really good improvements in terms of qualities, in terms of quality outcomes, and in terms of in terms of savings relative to a benchmark. So we saved Medicare, your government, $7.7 million over 3 years while we're in that program. You had to be at a certain threshold, though, for us to get any of that back. They said for the upside formula, you had to cross that threshold of 2.2% in shared savings in order to share it 50-50, half the government, half with us. That would have been 9.4. So we were at 7.7, we needed to be at 9.4. We got 0, the government got $7 million. You're welcome. So that's what we did. But we learned a lot. And what we learned was, how do you do this work? And so we started applying that to other groups, and we got about 80% of the contracts for Medicare Advantage, as well as for our work with Anthem, as well as for our work with Medicaid. So of the available population health pay for performance type dollars that are outside the fee for service, we earned a pretty good percentage. So 80% here, 70% here. Gave us enough confidence that last year we decided to go into more of a risk contract. So we said with CMS, we went into one of these APM models. So the APM model is called Next Generation ACO. That's their name they came up with it. And it's a full risk contract, meaning that instead of that 50-50 sharing and having a threshold, if we save anything relative to the benchmark, that comes back to us. However, if you go over, we pay that entire amount back to CMS. Well, we don't like paying more money back to CMS. That's not a good business model. So we have really learned a lot. We had 1 full year. We're still in the midst of the 2nd year. This can be renewed up to 4 years, and then we'll see what CMS comes out. That's their current version. They're still working on what's going to happen from this point on. Preliminarily, it looks like for 17, it takes them a while after the calendar year is over, but it looks like we did we did save some money, so we will be having some of that come back to us, and that's good. So that's what we intended, but there's intention versus execution, and so far so good. So that's where we're at. So risk. So are your patients as sick as you think they are? So the way that this is measured, this is one way. I'm going to give you an example because it tells you some of the new work that we're doing around this. A risk adjustment factor. So this is saying for an individual patient, how do we know? How do we know how complex, how hard it is to help this individual and express in numbers the complexity of what's going on? And you can never do that fully. So let's just say that from the start. You cannot. But we can try to get better at it. And so this is a numeric value which reflects the health status of a patient, and Medicare sets the average across all Medicare patients as 1. Right or wrong, they're just saying that's 1, that's the way we're going to do this, and then if you have it more than average, you're going to have a higher than 1, less than average, less than, okay? And the RAFA score is reflected on the following elements. Demographics, how old is your patient? Gender, there's going to be differences based on average patients in terms of how risky or how complex the care can be. Acute conditions, chronic conditions. Those are the 3 basic buckets. So if we look down here, it's a little small, but I'll explain it. So if you have a 76-year-old female, just for being 76, and for being female, she gets a score of 0.437. Well, that's a good bit below 1, so again, unless you tell that there's other complexities, that's going to be a low-risk patient, okay? Then you add on that she actually has a little bit of an income disparity. She is eligible for what they call dual, Medicare plus Medicaid, because she's lower income, she qualifies for Medicaid, and that adds a 0.151, okay? So socioeconomic factors can play into this as well. She has diabetes with vascular complications, okay? She has vascular disease separately, so you get a 0.368, a 0.299. She has congestive heart failure, and she has this combination. Some combinations are considered more risky than others, and so diabetes plus congestive heart failure adds a 0.182. And all of a sudden, we went from an original 0.4 to now more than 1.8. That's capturing the complexity of this particular patient. Okay? We have a lot of our docs and our ACPs and our teams that know how complex this care can be and making sure we get it right, but we hadn't in the past documented it in a way that gives us credit for it. So now we're trying to make that easier to do. So this is a form we came up with. This is not a real patient. Lou, we made up Lou. Okay, so Lou has a lot of factors that can go into this complexity. And the way we capture that is Medicare says at the strike of midnight on December 31st of every year, everybody's risk becomes 0. It's their system. I'm not going to try to defend it. It's 0. So then over the year, for everything you bill, then you build up to what the risk is. And collectively for a whole panel of patients, you have your risk for that patient population. But in the following year, for our example, for this nice lady who has all those complexities, if we didn't bill those same things at least once in a year, they think she got better. Ah, you cured her diabetes and her CHF, you're good, okay? That's not the case, obviously, but you have to code this once a year, because they say if they're not enough risks to at least assess once a year and put on a billing code, then we're not going to give you credit for it, okay? Even to the point where complexities like you have vascular disease and you've had an amputation. So you have an amputation, if you don't code it, they think it grew back. Silly, but it shows we've got to do this work and figure out how to do this. It becomes part of our routine. So we actually happen to have one of the architects of this form, Dr. Paul Barino, who I do work with. And so he helps to be able to say, how do we make this as easy as possible? And we thought about, do we get this into Epic? You know, we're in Epic all the time. How do we just start using this? We did some polling. We did some testing with this. We actually found that putting it on a bright colored piece of paper in the outpatient setting when you're getting ready to go in the room was actually a little bit easier than trying to find where it was going to be and get it incorporated into Epic. So in phase 1, we're still on paper with this, and we've done a good job. In terms of the potential to show the complexity, we're meeting that, and we're doing a better job with that. Now eventually, I know of other systems that have incorporated this into the EMR. Maybe we're going to get there. But this allows us to pull in other information besides what's in Epic. If they were seen at Lewis Gale for a condition that we may not have on their problem list, we can actually get that from claims now. We put that on the paper, then we're hoping that it updates on Epic. Okay? So there's different components we can add into this current process. Why is this important? Because we're trying to predict, not only to give us credit, but to predict who should we be focusing on. If we're going to put extra resources, you want to focus on the people that are at highest risk for poor outcomes and for higher costs. So this is an example from our partners. We partner with a group called Evolent Health, and Evolent Health has done some of this work and come up with a risk stratification process. And again, one example, there's others out there. We found that this one is helping us. So here's the contrast. Traditionally, we would say a 75-year-old woman with diabetes and COPD had 2 inpatient admissions in the past year and 1 ED visit, does not have a PC or did not have a PCP visit in the prior 6 months. So this is somebody that is already incurring costs. Okay, they're at $29,000 for the year, and we're starting to pay attention to. We're trying to help them, and that cost, if we do things right, is going to go down. Okay, so that's a good thing. So we want to continue to do some of that, but the new predictive pathways allow us to do this. A 66-year-old female with diabetes and coronary artery disease who's not been hospitalized and yet has some other challenges. 3rd percentile in terms of median income, lives in a food desert, 9 unique medications, including an anxiety medication that was never filled. She's a high risk waiting to happen. Okay, she's getting ready to go to the ED. She's getting ready to go to the hospital, potentially. And so she's starting off with a low cost, But if you can identify this group and prevent her from going up to 26,000, you've done the patient good and you really start to bend that cost curve. So that's some of the work and focus we're doing right now. So this is some of the work that they had done before we even started to work with Evolent, and they gave us some comparisons, something called a CSTAT. So if you had a crystal ball that was perfect, I look in it and I say, oh, I want to know if this patient is going to be hospitalized in the next year. So a 1.0 on a CSTAT tells me I have 100% accuracy. I'm perfect, I'm good. Of course, that doesn't exist. So how could you get? You go to the other end of the spectrum, if I flip a coin, 50-50. That's a 0.5 CSTAT. Okay? So how good is Evolent in doing this work with the software of predictive analytics? So we looked at it compared to Johns Hopkins has something called the Adjustable Clinical Groups, or ACGs. They're at a 0.67 and a 0.73 for ED and hospitalization. There's another group, another methodology called CCC, 0.61, 0.69. Another one here, and then Charleston comorbidity. You can see where they're ranging is in that 0.6 up to 0.7 range. By bringing in some of these other components, Evolent's gotten that up to a 0.8. That's the best we have seen. Some of the people come close to that. That's the best we've seen in the industry. That's what said to us, maybe this is somebody worth looking at and seeing how they built their model, and of course, not going to tell us all the details, that's part of their business plan, but if they can prove this and show that it works, that's what we want for our work as well. Flip a coin, so we say, well, what if I just ask John? John knows his patients really well, and he doesn't mind me picking on him. And he says, I can predict, I know who's going to be in the hospital. And we have some of that sentiment, and we think there's value in terms of what a PCP, primary care physician, knows about their own patients. But that value is not as high as we might hope. So if you look at this, we actually have some literature that shows for case managers, you're right at flipping a coin. Sorry, that's just what the data shows. Maybe we've gotten better than that, but that's where it showed. 0.56, only slightly higher for physicians. Interns did better. Maybe because they're spending more time with the patient, I don't know, but our best is our interns, so there you are. And so we overestimate the number of patients that will be readmitted and miss about 40% who are going to be readmitted within 30 days. It's just not good enough. That's not good enough for us. We've got to get it up higher, so we've got to use data, we've got to use predictive analytics along with our knowledge of the patient to combine to get where we think we should be. So again, how do we put this into action? So data sources I mentioned. This is administrative billing claims, it is Epic, it is Census Bureau, USDA data, and consumer data. All that's going into Evolent's Identify engine. So you have things about zip code. You have, if the patient lives here, are they high risk or low risk just based on where they live? Okay? That's some of the socioeconomic data that's feeding into this, along with some of our knowledge of what we know about the patient through talking to them from care coordinators and other surveys. We know severity of condition, acceleration of services, worsening of condition, socioeconomic status, distance to care, do they live in a food desert? Those are components that are going in there as well. Then machine learning algorithms, natural language processing to capture more of the data that may not be discretely coded, and geospatial analytics. And then you're trying to get to the prediction. This is the group to focus on. Okay? So what do we mean by focus on? That's care management. Okay? So this gets into people and interacting and connecting with our patients. So we have now 3 basic swim lanes, groups of work of interacting with our patients in this ecosystem. One is complex care management. So if you have a chronic condition and you have a certain risk score, you are eligible for complex care. Let's just use CHF as the example. So you have congestive heart failure and you have other risk factors, then we're going to be putting you in this program and teaching you how to self-manage better. How to watch salt, how to step on the scale, measure your weight on a regular basis, and know what to look for to stay out of trouble. Okay? So to be able to self-manage more effectively. And then this concept of, we're not going to be working with you forever, we're going to be working with you for a period of 3 to 4 months and you graduate. It's not a cap and gown ceremony, but it does say you've learned a lot and you know how to manage your condition. We can come back if you need us, but we're going to move on to other people who are just falling into that high risk category. And that's a sustainability aspect, so that we don't have more and more people that one care coordinator is trying to do 1,000 people. They're working with people for a period of time, graduating them, moving on to others. You can get refreshers, but hopefully we're able to make progress that way. Second is transition care. That's transition from any acute facility, hospitals obviously, but also could be nursing homes. That high risk in that 30-day period afterwards, how do we reduce that risk? Working with them, calling them with a certain frequency, making sure they know some of the conditions to look for to lower that risk. Do they know their discharge instructions, their medications, do they have transportation, and do they have a follow-up visit with the right people? Advanced illness care, so conditions that have gone to a point where we're not going to be talking curative. You know, you have advanced COPD, you have advanced CHF. What do you want? Do you want to not be going to the ER as much? Let's focus on that, okay? Do you not want to be hospitalized? We can focus on that. Do you want everything done? Let's focus on that. It's not telling patients what they want, it's asking the question and then working with them, working on symptom control. It may be different than, again, we're not going to cure this condition. We're past that point. So if they're eligible, really working with them. It is advanced care directives, so we can know what they want, and that doesn't mean that they're restricting them. It just means putting them on paper so that the team can respect it. So we're back to complexity, but hopefully with a little more purpose. So this is a primary care clinic, and all of a sudden they've got a lot of resources. So our model we started with, we had one care coordinator who've invested a lot of time, and they're really good at doing what they do, and they work with a growing number of patients, but you can see that they may get more and more patients, and you quickly outstrip the ability to work in a more in-depth and intense way. So we still have that person. This is, again, just for a generic one, but we have one care coordinator working on complex care, the primary one associated there, and then we have some other resources that are even using now technology on smartphones for certain patients to be able to track their symptoms. So that if we didn't capture them, maybe they are high risk or they're falling into higher risk, we have a way of finding that out earlier, then they get transferred up to somebody working more directly and intensely with them. We now have a whole team working on advanced illness care and one on transition care, and we've expanded into skilled nursing facilities. So now we don't own any nursing facilities, but we do partner with them. We have a collaborative with the ones in the Roanoke Valley and the New River Valley, and we're going after specific aspects of length of stay, outcomes, readmissions, and partnering with them to be able to figure out how to do this better. And now other services that we've not had in the outpatient setting, behavioral health, social work, pharmacy in the ambulatory setting to kind of extend what we have in the inpatient setting. How do we connect those dots and provide more resources? Keeping that time change. So just a couple examples of what does this result in. So for ER, if you can see, this is kind of a gradient of risk. We had, for next generation, our 45,000 Medicare patients. We had 5,500 of them who had about almost 10,000 visits. But how do you break that down? You had 3,000 of them that just had one visit. Okay, so if they just had one visit and no other real high risk, we may not be doing a whole lot. But then you get in the secondary category, 4 to 9 or 10 visits each. And then you get in this very high frequency, one person had 55 visits to the ER in 1 year. That's a lot of visits. They're hanging out there. I'm sure Dr. Burton and his team know that person by name. I don't know who it is, but how do we help figure out the drivers for that? Okay, so this becomes a risk stratification, and we do different things for each group. Okay? Readmission work. There's a whole team working on readmission work, trying to figure this out. What are the best practices, and how are we going after different aspects? And we're using a different tool called Javion to assess risk just in the readmission period. And what that allows us to do is to come up with some very specific clinical recommendations. So to reduce readmissions, I won't read them all, but top 15 it has, and a lot of them focus around this. Accessibility of prescribed medications and the obstacles to taking those in the way that they're prescribed. Do they understand them? Can they take them 6 times a day? Do we really need to give medicine 6 times a day? Or can we consolidate that? Can they afford them? Are they having side effects? That's a big part of this that is some of the early focus of the work. We focused on heart failure with readmission work as well, and we have scales now that we give out. So your CEO, Nancy Agee, in a discussion with her, she said, if people don't have a scale, why can't we just give them one? Well, now we just give them one, okay? And these are low cost. We got a good rate on them, but they're pretty good scales and they're pretty accurate. And this sign on here, this instructions is actually embedded in the scale. You can't rip it off. It's not a sticker. It's actually on there. It says, call your doctor if you gain 2 to 3 pounds in a day or 5 pounds in a week or have any increase in shortness of breath. Tips for using this scale. Same time of day, wear similar clothing, write down your weight, and limit your salt intake. So it's those instructions, and they're going to see them every day looking down the scale. Okay? This has been shown in the literature to be helpful. We adopted techniques that we think work and are starting to see some progress with these types of interventions. In the post-acute space, I mentioned we're working more directly with the nursing homes. One success story I'll share with you is around our patients with knee and hip replacements. So for replacements of joints, that is really changing rapidly to being a hospital-based service to now being an outpatient-based service. But at this time, when we first started doing this work, we had variability in our surgeons, in our orthopedic surgeons, in terms of how many were referred to go to nursing home versus home with the right home health or other support. Pretty big discrepancy. So we shared this with Dr. Moskow, and he shared it with his group and said, there's no reason we need to have that amount of variability. And all of a sudden, we really started doing some focused work, and you can see the red is the number that went to nursing homes versus home. That's for hip, and now that's for knee. Okay? And no change in terms of readmissions, no change in terms of quality outcomes. So getting the same outcomes with lower cost. Okay? We have a scorecard now for the SNFs that we developed with them and are actually starting to look and see how they score versus each other. Guidance about where to get care is a brochure that we have as well, and this shows for certain conditions, should you call your doctor's office, should you go to the urgent care, or straight to the emergency room, or call 911. Most people you think might have that, you'd be surprised. You know, it's saying, my ear hurts and I called 911. No, that's not the best, you know, and so we want to have good access. We don't want you waiting for 4 hours in the emergency room with a cold. We can get you fast access, but we've got to make sure it is fast and appropriate in these other settings. So we're trying to guide some of that, and then through our access work, make sure that we can be convenient and low cost for our patients. All right, last one. Okay? May the fourth be with you. So this is the fourth aim. So anybody know what the triple aim is? Hands, anybody heard the triple aim? Oh, good. Let's go ahead. So the triple aim is something that Don Berwick was a pediatrician who had his father get hospitalized for a heart attack. And it was substandard care. And he was appalled. He said, we can do better than this in the U.S. for healthcare, for outcomes. And so he started something called the Institute for Healthcare Improvement, which is now a very robust organization that's come out with a number of things, but one of them is this concept of the triple aim. We have to do multiple things at the same time. The triple aim is the best possible outcomes, the best possible experience with controlling the costs. Okay? Since that time, we've added on a fourth one. The fourth aim is we have to sustain the teams that are doing the work. So this concept of burnout, which is very real, and we're seeing it among physicians, ACPs, staff members, this is hard work. This is very hard work that we do. How do we address that? How do we sustain that? So that's what the fourth aim is. We did a survey in our system, but I'm going to point out some of the results in the Department of Family and Community Medicine. And this was a wake-up call for myself and my leadership team. We found that we were no better, and that's the way I'll put it, no better than the national average, which is appalling. The national average is we're having 61% of our physicians and ACPs who are at risk for burnout when we first did this. High risk for burnout. It's 2/3 of your workforce. Right? That's not sustainable. So we have been conducting for the past almost 3 years now kind of a deep dive into looking to say what drives this? What are the things that add to that sense of feeling frustrated, depersonalized, you know, this is not bringing me the joy that I'd hoped for. Well, not to be surprising, I use the nice homework cartoon here, epic failure. You know, EMRs, I don't care which one it is, Cerner, there's none that people say this is the solution. No, they're all challenging. Okay, the documentation aspects, the frustrations of the EMR are definitely there. So how do we make that better? And that is definitely a work in progress. Is there enough staffing? What kind of ratios? Are we even looking, saying for family community medicine, we have 55 sites. The staffing ratios, are they really, what are they based on? And do we have enough staffing, too much staffing, too little? And we probably had a little of all that initially in the department. Workload, so things that are now, we're supposed to be going towards paperless with computers, we are far from paperless. We have prior authorizations, we have FMLA paperwork, important things, but a lot of paperwork that are not necessarily allowing patients and their docs to spend more time together. Okay? Change, I just mentioned that. It's hard to avoid, but it's one more thing, and you think, just got this down, and now you're throwing something new at me. And then this perceived and actual, in many cases, loss of autonomy and voice. More and more groups are having a hard time staying independent, where they might have more voice. Even there, they don't. My wife's in independent practice. She tells me this all the time. But we're joining institutions. There's a lot of power in institutions. It's also different. You know, we have to do things in a way that is sustainable, and that means sometimes everybody doesn't get to choose their own path. How do we then still tap into the ground level wisdom that those doing the work really have? You got to seek it out and you got to ask. You can't just say, my door's open. I figured they'll let me know if there's a problem. No, you got to go out and look. So we started to address all those things. We focused on this concept of vitality. We had a fourth aim committee that was led by our vice chairs. We made this a priority in every monthly meeting that we had about our work in this as a leadership group. I would send a summary out to all of our providers and the site managers. We started working on this paperwork and other workload and saying, who's the right person? How do we support this? We centralized some of it. We said, some of this we don't have to have happen in the office. We can do this in a centralized fashion. We continue to work with our TSG colleagues in trying to improve this. I think we have seen some things on the later versions. Again, I'm going back 2-3 years ago. I think we're making progress. We're not done. And then really trying to develop the leadership, the regional and local leadership, so they can get that ground level input and help that autonomy aspect. And here's what we saw as we went from 61% down to 46%. We're not done. That's still about half, but it's less than 2/3. So it was a move in the right direction, and we think it's critical to being able to do any of the work that we do, especially if we're talking about this new population health work, is we've got to pay attention to the fourth aim. So we see that as wrapped up in a part of making this work and sustaining. That's what I have for you, and I welcome any questions.
I'm going to also open up the lines, I think, if you stop for so that we can accept questions from remotely as well. I think that was excellent. Thank you so much. I feel like at least I have a much better understanding of population health right now, or at least I could probably formulate some questions a little bit more articulately now. So I will save my questions until later, but please ask questions. For those of you online, please feel free to ask Dr. Jeremiah whatever questions you may have.
I think we had a hand up over here.
Sure. You know, I guess 10 years ago, I was on a committee when I was at the VA, and we were talking about doing this and doing that, and I mentioned that there are places that have been struggling with how do you get the best care in a capitated system. Places that have been working with this for 50 years, and why don't we just latch on to what do they say is best practice? And people looked at me like I had three heads, like, what do you mean follow somebody else that has great outcomes and low costs? I mean, why would you even suggest that? Because we're the best ever. Of course, I was at the VA at the time, but this was a question I had then, and after I got that response, I was quiet and never asked a question like that again. And seeing this, it comes up again. I mean, there were 24 people in here. There's less now. That means that there's 48 years that we would not get on average, where our neighbors to the north would, as far as average life expectancy. And there are places that get so much better outcomes with such lower costs. And it always occurs to me, I don't know that much about comparative medicine, and I know that it's not only the healthcare. Like a lot of things that you talked about are medication compliance with heart failure recommendations, and we know these are important, but that's not the only thing. That lifestyle, and we only have a certain amount of capacity to impact lifestyle, which is where the greatest benefits come. A lot of us believe that. But I wonder, when programs are developed, how much other areas, the people that you look at in population health, and they're the ones who have the greatest life expectancy and the greatest healthy adult life expectancies at a fraction of the cost of what we spend per capita. And I know, like as a provider, I know the physicians are working very, very, very hard, and the healthcare system is working really, really hard. And we have the outcomes that we have. And you know, a lot of us after a while, it's like, well, you know, I'll focus on best practices best as I know. I'll focus on what is the things that I can do. But it's a curious situation.
So I'll give you hopefully a different answer than you got from the VA those years ago. I think we should have no hesitation to take any best practices we could find and see either how we can adapt them to work here or figure out why they wouldn't work here. I think that's an obligation that we have. It's the same that we do for evidence-based practice. So it's not like I expect our own group and even our own research institute will come up with all new answers. That would be naive, it would be arrogant, and I think it's wrong. And so I think we have to look for the best answers. And we do. And so there's actually forums that we're a part of right now that we come together from across the country, and really it's international, you know, in its approach, and saying what are the things that have been proven. Here's one of the challenges with this, is that when we say something works, okay, so let's say the scales. I'll use something simple example. I'm doing scales for our patients with congestive heart failure. And those with scales that we've given a scale to tend to have less readmissions than those without scales. We haven't set up much of the science and the research on population health as a controlled trial. So therefore, you have a lot of associations. Those with lower readmission rates have scales. They might also have a very tiny salt shaker or none at all. They may have had better education. They may have home health. And I call it the kitchen sink phenomenon. So you're throwing a whole kitchen sink of interventions, and I don't know which one has the best driver. That's true of everybody, it's not just us. And there are getting to be better study designs so we can answer that question of, is doing home health visit versus a scale have equal weight? Because throwing the kitchen sink isn't good science, and it's not easily sustained in terms of cost. So I just mentioned that as a complexity. It's a challenge for us, but I think we're getting better at it. But many of the things we're using did not originate here. We're saying it worked for you, let's see if we can make it work even better here. So I call it R&D rather than research and development. It's rip off and disseminate. So it's fair game. And there's a group that Don Littlepage, who's my dyad partner in this work, and we attend on a regular basis, meets twice a year. It's called the Leaders Board. It is others that are leading ACO work, and it's got Geisinger, it's got Kaiser, it's got Wake, it's got UNC. I mean, it's all of the regional and even national big players in this. And it's an open forum, and we share ideas and say, if you can make it work better, go to it. So I think it's a great comment that you've made, and it's something that we have to do well. So, thank you. Other questions?
Michael, are we looking into the hospital at home concept, or trying to grow certain sections with challenging access issues, trying to get people in the right venue for their care? I see a lot of people in the inpatient setting, some of them who need to be here or need to be here for a period of time. And if we had other resources, we might be able to provide better, safer care in a less expensive, less risky venue. I've heard about other communities around the country, a few experimenting with those types of things.
Yeah, a great question, John, and you're right. There are some that are getting pretty advanced in terms of what you can provide at home with the right resources, and you can be doing infusions, you can be doing a lot of care that we would normally do in not only kind of a regular hospital setting, but maybe even in a unit. So I think, or intensive care unit. We're looking at that very closely. I think the first step we've had is looking at post-acute care. So post-acute care, do you need to be in a nursing home or an inpatient rehab versus home? And we've already seen some success with that. I think the challenge of moving a large volume of patients in that direction is it creates a different infrastructure. Do you have not only enough robust home health, but you also have the clinicians to be able to help support that work? And are you pulling them out of the hospital to do that? And the reimbursement is less. And so this gets into this is the metaphor, is the foot in two boats, or foot on the dock and foot on the boat. This is something that we know is the right thing to do, and we want to do it well, and we want to be poised, but until you have a payment system that fully supports it, the majority of our revenue still comes from fee-for-service.
Right.
So we don't want to lose opportunities and be ready to move into this, but we're not in a capitated system. In California, you'd already been doing that, but they have very different payment systems than we do here. Kaiser's been doing this for a long time, and they do it in different ways in a much faster pace. We are ahead of a lot of people who are in our kind of environment, but if you leap into that, we would have trouble making any margin, because again, we have a lot built into our hospital facilities, and you can't just turn a switch and shut them down. I think that's the movement. I think it will continue, and the question is the pace and how do we get there in a smart way. So, great question. Tyler?
So Dr. Jeremiah, you mentioned kind of the 3 swim lanes that you have now in terms of complex care, transition care, and advanced illness care. And my question is, how are the swimmers doing in those lanes in terms of what's the patient experience, patient satisfaction with that, and then also the staff and teams that you have engaged?
Wow, that's actually a more complicated question than you know, but it's a great one. Because it's really saying, how do we measure progress or success? One way that we do that is we have goals set for each of those swim lanes. So the number of high-risk patients that are referred into them, the number that go through the programs and graduate, and we're doing great on that. We did great last year, we're doing great on that. We're right on target with all of those aspects of just the process. And we think it's, again, something that Evolent and other partnerships in other parts of the country had already proven. We're doing our own flavor, but we're making that work. In terms of outcomes, we're looking at clinical outcomes as well as satisfaction outcomes. Some anecdotal here. You have our patient engagement and patient satisfaction surveys. They're not unique to just NextGen, but they do give us a flavor of, are we doing this work well? And then we have stories. We have some wonderful anecdotes. That's not data. I think it's a combination of both that really tells the richness of the story. The data shows that our clinical quality outcomes during our 4 years of MSSP and so far in NextGen, we have a steady climb. We still have opportunity. We can close gaps better. We can have still better outcomes, but we're moving in the right direction. And then there's the financial sustainability piece. Is it working? Are we paying a check back to CMS, or are they paying us? But are we doing the work well enough to bend the cost curve and have a reduction of unnecessary or avoidable utilization? And I think so far in 2017, it's yes. And we're seeing that starting to have ripples with our Medicare Advantage plans and the other groups that we're doing this work on as well. So I think we're moving in all those parts. I won't say that we're doing as well as we can, because I don't think you ever arrive. There's always more you can do, but I like the trend. So I think it's working well. Now, one last one, you said satisfaction of the providers and the staff. I think that's a work in progress. I think part of it is saying it's one more thing. You're going to give me a brightly colored form. It may look pretty, but it's another form. And then even the care coordination model. We started back in 2009 with an embedded model. We had care coordinators in each of those 55 sites. The advantage to that is you have a relationship with that individual. I've got somebody working right there, and I see a diabetic patient, and again, remember, I'm using my own CSTAT, which at best, if I was an intern, is 0.59. But I'm saying, I need care coordination for this patient, okay? I'm not saying if you do or you don't, I'm saying the data is not necessarily supporting that, because we weren't informing at that time with that more robust claims and EMR data. So in order for them to focus, we had these care coordinators doing a whole range of different jobs and services for an increasing number of patients. We weren't seeing that that's sustainable at that level to do that well. I think we're moving towards a model that is, but that transition is challenging, because I hear frequently, we miss having a care coordinator in our office all the time. And I understand that. I anticipated that. We're not unique. A lot of systems are going through the same change too. The way I look at it is our care coordinators are now very much patient-focused, not necessarily site-focused. But it's still, how do you make that work? How do you foster the relationship piece as best you can, but it won't replace what it was. So that's part of our change.
Just a quick follow-up question to that. Patient satisfaction with regard to our more proactive outreach to them, saying, you've identified some things for you that we think you could benefit from. We'd like to invite you to participate in this. How are they responding?
What I continue to be pleasantly surprised about is you keep thinking we may have hit a saturation in terms of our use of technology and even telephonic outreach, use of cell phones, as well as face-to-face. But even our patients, this is a Medicare population, so it's an older population. They're embracing it. They love my chart. This Healthy Every Day, which is I'm going to take every day, I'm going to put in my symptoms. It's almost like Virgin Pulse, and putting it in every day. But they love it, and they really are. We're finding that an increasing number want to take advantage of that. Now, not everybody, obviously, there's changes in that, but differences. But I think the satisfaction is there. And then, of course, for people who get connected to either resources we're providing or community-based resources that have been available that they never knew about, those are some really powerful stories. And there's some huge satisfaction from that, too. So I think, again, the vast majority of the feedback from patients has been extremely positive because it's connecting the dots for an increasingly complex care system and ecosystem that they have no idea how to navigate. So they love having somebody who can help them move through this. I think that's something that's a clinic model, but it's a very powerful part of it.
It's been wonderful. Thank you so very much.
Appreciate it.